Okay, good evening, all, and welcome to another episode of Heart Support Connect. I'm your CEO for Heart Support Australia, Christian Radicchio, and tonight we have a special guest with us, a friend of mine and a very close colleague, Dr. Matthew Hollings, who will be giving us a special presentation on resistance training and the importance of resistance training in cardiovascular disease patients. It's an area of significant importance. Typically, an area that we sometimes kind of neglect in around when we talk around exercise and physical activity. And we sometimes always forget to talk about resistance training, and it is very, very important into patients' longevity, not just even just during the aging process, but also in relation to the cardiovascular disease. So it should be a great topic tonight and something I'm sure that all of our groups will share afterwards, and even some of our relationships that we have with the cardiac rehab center. So just as a brief introduction, and we'll take you straight over to Matthew. So Dr. Matthew Hollings is an exercise physiologist and a postdoctoral research fellow on the NHMRC Synergy Grant Solve CHD, which is a multidisciplinary research project looking to transform the post-discharge care for people with heart disease across Australia. Within the program, he leads a number of projects centered around improving the quality and uptake of exercise post-cardiac discharge, including the potential role of emerging technologies. Dr. Hollings is also part of the Cardiovascular Initiative leadership team, holding the position of implementation and policy clinician lead. In addition, he holds positions on this one with me with the Executive Committee of the Allied Health Science and Technology Council, on the Cardiac Society of Australia and New Zealand, and also on the National Education Committee. He also holds positions with ACRA New South Wales ACT and also with NHMRC Centre Research Excellence. So overall, an early middle career researcher, an up and comer, and a great person to listen to in relation to resistance training. So without any ado, I'll hand it over to Matthew to talk to you around resistance training in patients with cardiovascular disease. So on that note, I'll make you now the host and you can take over.
Excellent. Thanks for the invite, and thank you to everyone for making the time to join me tonight. I will apologise in advance if my voice is a little croaky. I've had a nice little daycare bug over the last few weeks, so trying my best, but the perks of having young kids in daycare. So for me, Christian's given me half an hour to have a chat about resistance training. I always like to be very pragmatic in when I present. So what you'll see is very much a snapshot of sort of a few little things. I'm not going to go into too much detail on a few little things, but I definitely want to finish with some stuff that you guys can take away, whether you are a clinician or whether you are a patient or just someone interested in this area. So by all means, contact details are up on the screen at the moment. Hopefully you guys are seeing that well. Do let me know if anything, any hiccups pop up in the meantime. I will pop this up at the end as well to be helpful. So I'm going to kick off with maybe something a little bit interactive. So you'll see the QR code in the top corner. If you want to play along, if you guys have phones handy, for those who are on phones, it's going to be a bit difficult. But if you're on a computer and want to play along, I just want to find out who we've got in the room just to help me as I sort of move forward and sort of into this presentation. So you should be able to scan that code, and hopefully that, if technology gods are going to work with us, that should take you straight to a little quiz, which will let you choose one of these options just to get a bit of who's here. And do let me know if there's any issues. I might make sure I play along as well to see the issues before they pop up. Very nice. I'll give you a couple more minutes. If anyone is having any issues, do let me know. Looks like we've got good representation of clinicians. Interested to see if there's any patients in the house as well. And thank you for that. I see in the chat we've got someone from Flinders as well. Excellent. What I might do is I'm going to pop along to the next slide, knowing that I'm limited for time. There we go. We've got a researcher as well. Um, and maybe just having a look at where we're from as well. I'm obviously coming here from New South Wales. Let's see where else we're from. So you should be able to stay on the same thing on your phone, and the new quizzes should pop up as you see them. I can see that we have got a few good responses. The computer here looks like it's lagging, but I can see that we've got a couple of Vics, someone from South Australia, a couple from Western Australia, which is excellent, and a Queenslander. Thank you, Steve. ACT for Bob, beautiful. So it looks like we've covered pretty much the whole country, so that's good to hear. So I have got a couple other ones as we go through. We'll see how the technology goes. I'm not going to stay on that too long because sometimes it just doesn't work. So I'll get straight to it anyway. And by all means, I'll keep half an eye on the chat. You guys are welcome to unmute yourself and talk if you have a question at any time, or pop something in the chat and I'll try and catch it and address it at that point. So for me, really quick overview of what we're going to cover in the next half hour or so. I'm going to really quickly touch on something you all probably heard of. You're probably aware of the benefits of movement in general. Cover that off so we're all on the same page to start with, and then we're going to start to hone in on resistance training as a particular type of exercise. We're going to talk about what it is. We're going to talk about why it's important. Does it work? Is it safe? And then I'm going to leave you with some practical strategies that you might be able to put, whether you are a clinician in clinic or whether you're a patient interested in this at home, or if you guys are in a supervised setting as well. So I probably don't have to tell the room there's lots of health benefits to, I'll call it movement, but we can call it physical activity. I'm going to define those things later. You can have a quick look what's on the screen here, but we know that moving is really important for pretty much protection against most diseases across the world. When we look particularly, and this is a nice little figure here, we look at on the bottom axis there, we've got the amount of physical activity minutes in a week. And then we've got the relative risk of death on the vertical axis there. So there's two things I want you to take from this slide. The first one is that you'll see that once someone has cardiovascular disease, their risk of death increases regardless at any point. However, if you look along the continuum there, activity that you do, the more protection you get against that. And at some point, the two converge up around 1,700 net minutes a week. There tends to not be a difference between whether you have cardiovascular disease or no cardiovascular disease. So sort of probably not saying anything new, but sort of just reinforcing, and probably reinforcing point number 3 is, if you pay attention to the steepness of the curve, sort of from 0 to 500 on both of those colors, you'll see that the biggest benefits come from a person doing nothing to doing a little bit. So it's not, there's all these recommendations to do lots of physical activity, whether it's 150 minutes a week or 210 or whatever guideline you look at. But the biggest benefit we see in patients is for those who go from nothing to a little bit. And that's something to really keep in mind. And that will also stay the same as we move through different types of exercise like resistance training. I really like this study. This was a really well done study that came out last year. And this actually looks at a cardiac rehab cohort. So someone after they've had a heart attack and comes in the cardiac rehab. And the main message from this really is that if you do exercise after your event, regardless of whether you are inactive before the event or not, you will have some protection against all-cause death and death from cardiovascular causes. Compared to someone who goes from active to less active, maybe they're losing confidence after their event or something like that. Those people actually don't have any difference in their outcomes compared to someone who just remained inactive before and after. So really important, again, reinforcing that point that doing anything, regardless of whether you started with something or started with nothing, is really important. There's heaps of benefits that will come from it, and I'll have some figures later on, but, there's a range of other benefits as to most of these are going to be important for most patients, particularly, as we get a little bit older, and some of these things like quality of life, mental health, and cognitive function become really, really important with aging. But there is a particular definition that I want to hit on as we now move sort of from that context into looking at exercise and resistance training particularly. So when we think about physical activity, this is sort of a broad term, and that covers basically any bodily movement. Okay, so that covers whether it's something you do, you're sitting on the lounge at home, you walk into the fridge, or you're doing a structured exercise program. That sort of is all encompassing in the term physical activity. Now, exercise is a subcomponent of physical activity, and that has to do with a structured session that is particularly focused on improving a particular outcome, whether it's fitness or whether it's strength or one of those things. So that comes under the physical activity banner, and it really has to do with that structured, my intent is to improve a particular outcome from doing this. And resistance training sits within that. So leisure time, it's not, I guess the best way to look at resistance training is, and by giving you this, is that resistance training will come from a structured approach. So there's a few things that we need to do, and particularly that we need to formulate for our resistance training to get the proper outcomes, and it just has to be structured. So that's sort of what I wanted to give you, at least before I jump in to the next part. So for the next part, again, we're going to jump into, I think, yeah, so I might just move forward on that one. So hopefully at this point, we should now have, you should hopefully, for those who are playing along on the app, I just want to get a bit of an idea, and for those who don't have the app, by all means use the chat. The question here that I'm struggling to see on the screen here, but I might just shift you to the other screen where we can see it. The question here is, I just want to know what you think about or what your awareness is of resistance training at this point. So what is the first thing that comes to mind when I tell you the term resistance training, knowing that I haven't really defined it at this point? So just one word or a couple of words that can help define, give us an idea of what that means to you. Excellent, perfect. So this is going to give us a bit of a piece together of what people's awareness of this term is. That out as we go, and like I said, by all means use the chat if you haven't worked the app out. That's completely fine, and you can put it in a number of responses. So if that does mean more than one thing to you, you're welcome to put in a couple of things, and I won't hang on too long with that. Looks like we've got 4, so if no one's got any other extra words, so the term weights, yeah, training, excellent. Strength, weights, therabands, they're all things. Push-ups, Bob's popped in the chat. That's excellent. So yeah, these are all things definitely definitely they're associated. What I'm going to do after this is I'm going to give you a nice clear definition. Push-ups, perfect. And I mean, in a nutshell, you guys are spot on, basically. So all of these terms do cover it. Is for a really clear definition, I guess. By definition, resistance training requires contraction of one or more muscle groups against an external resistance. And so a lot of those things you guys have mentioned, weights, push-ups, therabands, they are all classified as external resistance. And the important thing about this, like I sort of flagged earlier, is that there is the intention to enhance muscular adaptations, and whether that's strength, muscle mass, or endurance, that probably is the key part of this. So that probably differentiates what we might call leisure time activities, something like carrying groceries or things like that. So things like that might be part of your daily routine, but I mean, some people might, but often you may not be carrying the groceries from the car with the sole intention to improve your muscular strength. And so I think that's really what defines the difference there, and what really makes the importance of, we need to have this structured program so that we can really improve this for the reasons that I'll cover moving forward. So the other thing about this is that just like any other treatment for any other disease, exercise should be individualized. And I've got that term up because as Christian alluded to early on, it's often resistance training is the forgotten little friend, and I'll give you some stats a little bit later on about that. But often, many people, if you ask them what type of exercise they do, it would probably come or something like running on the treadmill or going for a run or something like that. So it is important, particularly, that we look at the requirements of patients or your requirements if you are a patient, what are you trying to get out of an exercise program, and then making sure that we individualize that program. So if you are someone who is a little bit weak and frail, resistance training is something that would certainly need to be in that program. Whereas you're someone who's maybe a younger person looking to improve their fitness, that's where we might individualize in a slightly different way. All right, so moving forward again, and I've got a couple here. Don't know why the technology gods aren't working with me, so I might just shift over the other screen again. So apologies about this, guys. So again, on our next question, um, I just want to get a bit of an idea again from the room. Have you ever regularly participated in resistance training? And you can use that term regularly, however you interpret it. Just getting a bit of an idea how many people are. I might just throw some numbers up. That's probably a bit easier. So everyone on there, yes, has. Looks like I'm speaking to the converted here. I was hoping to have a few more no's so I can try and convert you. But that's excellent. We're going to move to the next one. And on the next one is just I want you to reflect on the last 4 weeks, and about how many days do you engage in this. And the reason I'm doing this is because I'm going to give you some stats a little bit further on, and you'll be able to sort of compare where you sit in conjunction to where some others might sit. That's excellent. And I'm looking at the chat as well. It looks like we've got a really good group of people here. So you are my people by the sounds of it. Very well done. So 3 to 4 weeks, 3 to 4 days, 3 to 4 days. Looks like everyone on there is saying the same thing, which is excellent. So just going to pop back to the other screen again. A 1 to 2, excellent. Anything is better than nothing. It's good that I've seen no zeros. So you guys should be back on the slides. Let me know if I mix that up. But sometimes, maybe not in the case for those listening at this point, but maybe there might be some listening to this in the future where sometimes resistance training gets a bad rap. Particularly, I see this with a lot of women that I work with who sort of think that if they lift or touch a weight, they're going to turn out like this guy. And it's really important, if you are sitting there either as a clinician speaking with a patient, or if this is either yourself or someone that has this perception. It takes a lot to get to this stage, and a lot of bad drugs as well. But besides that point, it's training probably 12 to 14 times a week, looking after everything that goes into your mouth to even get anywhere near someone like this. So really important to sort of break down those stigma, if there are stigma associated with it, with anyone you're dealing with, and just reflect on the fact that resistance training is for everyone, and it certainly is beneficial for everyone, and particularly for those who maybe are losing muscle mass, or for those who, through the aging process or through disease processes, feel like becoming a little more frail, maybe feeling like you are maybe not as strong as you used to be. Maybe things as simple as carrying groceries or opening jars are starting to become trouble. And that's when, that's when we see the most benefits from something like from this resistance training in particular. So why is it important? What I wanted to do here is there's many reasons why it's important. I sort of want to hone in on one, and the term pandemic is one that we've been become quite well acquainted with over the last couple of years. So the definition of the term pandemic is a disease that spreads over multiple countries and places an increased stress on the health infrastructure. Um, so I want to be somewhat controversial and say that, we've all got a pandemic that is spreading at the moment, and that's just aging. It's something we're all going to be exposed of. It's as certain in life as taxes are. And it's only going to increase over time, and that means the expenditure is going to increase over time. So we know that aging is a pandemic that will not go away, and so there's things associated with aging that that we need to address, and think about the right way to address those. So one of the most common diseases of aging, if you haven't heard of it, is sarcopenia. So the correct definition of sarcopenia is the progressive loss of muscle strength, mass, and function. So important. It used to be, the old definition was just losing muscle, but we actually talk about it as losing muscle and other qualities associated with muscle loss, so which is strength, which is function, so the ability to do stuff, every day. Um, and we know that this disease is associated with an increased risk of pretty much everything, everything that doesn't look great as you age. So it is one of the most prolific. It's not well documented because it's not well screened, and the international consensus is that there is no consensus on how to define this. So it's a really murky area, but we know it happens. I mean, you guys only have to use the eyeball test to look around at someone who maybe is aging and they're shuffling a little bit and they're looking a little bit frail and weak to know, okay, well, that person looks like they're either losing muscle mass or they're not as strong as they used to be, to sort of see this in the real world. Now, when we sort of bring this disease into cardiovascular disease, what we know about this is that 1 in 3 adults over 65 with cardiovascular disease will have sarcopenia. So that's, 1 in 3 of the patients over 65 that you might see in your clinic or that, friends or family of you guys is likely going to have some clinical definition of sarcopenia. Now, it is a funny little relationship, CVD and sarcopenia. It is really like the chicken and egg. It can really go either way. So we know that people present with sarcopenia have a chronic inflammation, and that can lead to cardiovascular disease or, accelerating the progression of cardiovascular disease. But we also know that the inflammation associated with cardiovascular disease can also hamper the muscle, lead to loss of muscle, and I guess decreases in physical activity levels, which can lead to losses in muscle mass as well as strength and stuff like that. So it is really a nasty little thing. And once you have one or both of those, if you don't do anything about it, it tends to spiral fairly poorly. The one thing I didn't have on this slide is that people who do have both of these factors tend to have a significantly worse prognosis than people who have either one of those two. So it is something that is very prolific, and it's something that needs to be addressed fairly well. There are a number of treatments for sarcopenia, but the most effective treatment is resistance training. If you look back at that definition I just gave you of sarcopenia, the only way to reverse losses in muscle mass and strength is to reverse it using a stimulus that can reverse it. And so resistance training is the only documented one. Obviously, if it has to do with things like, losses of muscle mass and stuff, nutritional interventions can help with that. Also, dealing with medications that may be causing that as well. But when we look at reversing it, resistance training is certainly the main one there. When we look at does it work, I'm not going to give you a whole lot of data here just because I didn't have a lot of time, but in short, yes, it does work. I've got two really good infographics that I love presenting stuff like this because it's a bit easier to digest. Two really nice recent studies that have sort of pulled all this, so I don't have to give you a whole lot of boring things. You're welcome to have a little bit of a read around there. But it works in a number of different ways, and I guess if we look up in the top right-hand corner of that, the right-hand infographic, the most important thing probably, for some people, I guess for those medical personnel and our clinicians, is that it improves our prognosis, and it improves, or lowers the risk of death and future hospitalizations sort of as a total. And if you're a patient looking at this, you probably are caring more about things like, the top left, hopefully you can see my mouse there, but increasing your quality of life, increasing your independence, reducing your falls risk, and maybe even down the bottom, there is quite a bit of evidence that suggests it improves bone mineral density as well, which can help sort of, I guess, slow the progression into osteoporosis and hip fractures that may be associated with that. So there's heaps of benefits. It certainly does work in many different ways. And if you needed, those two papers are really good places to start if you did want to read any further into this. Is it safe? And this is often one of the more controversial things. So I work with a lot of people in the medical field, and one of the goals in my professional life is to try and convince the medical fraternity that it is safe. And there's quite a good amount of data coming out there. We just need a little bit more as well to help sort of put that point. But in a nutshell, yes, it is. Obviously, I'd have a little asterisk there, is that there will be some cases where maybe it needs to be explored in certain patient cases, but for the bulk, and I'm referring to people with cardiovascular disease here, it is safe. We published a big review a couple of years ago now that pulled any resistance training study that had ever been done on someone with coronary heart disease. That comes with this that our adverse events weren't well reported. We had something like 35 papers in this study, and only 6 of them actually reported whether adverse events happened or not. But the majority of those were during aerobic exercise. Only one of the 63 cardiovascular complications, which can just be things like, things picked up on an ECG, whether it's someone having chest pain or things associated with exercise like that. Only one of those happened during resistance training. The rest of them happened during aerobic training. However, what we do see with resistance training, particularly if it's done poorly, is that most of the complications that happen are musculoskeletal in nature. And that is just because that's how we're loading it. So people who come in with existing osteoarthritis of knees or backs or something like that, often it's exacerbations of conditions like that, which can certainly be worked with. I've been on quite a few large clinical trials where we've had patients from 65 up until 102, and we've had them doing quite high intensity resistance training. And for those who do come in with those type of complaints, we can certainly tweak it, and there are always ways around it. So that, I guess, broadly from a safety perspective, one of the other things often that is flagged with weights training is the cardiac safety. So hemodynamics, if we talk about blood pressure and heart rates. Again, I'm not gonna bore you with too much data, but a couple of key papers here looking at the changes in, so that you'll see the blue line there is systolic blood pressure, and then the red line there is heart rate. And so if we look at the changes from rest to exercise, we see much larger changes in both of those when going into an aerobic style exercise when compared to, we've got 3 different versions of resistance training exercises here. So again, these were all matched for intensities. I don't think they were maximal. I think they were probably around 80-85%. So it was still a good amount. But you can see sort of some of the things, and I'll give you another one in a sec. But often, I guess some of the things that are often flagged to me by clinicians and patients is that they're scared of increases in things like blood pressure. And when we look at the data on resistance training, we do know that blood pressure does spike pretty severely, but we also know that that only lasts about 2 or 3 seconds. And often it's not enough for something like heart rate to catch up to sort of overload the heart in many instances. Obviously, there's going to be some instances like patients with weak arteries, I guess, or a condition relating to weak arteries where big spikes in blood pressure may be an issue, but for the bulk of people, it won't, particularly when it's that short. So the other thing that's sort of come out is that what happens with weights training is that regardless of intensity, and sort of what we're looking at here is we're looking at the systolic blood pressure on the vertical column, and we're looking at different intensities of exercise. So the little white dots there are someone doing a 90 to 95% effort for only 4 repetitions, and the other one is someone doing probably about a 60% effort for 15 repetitions. And what we see is that it tends repetition that drives both heart rate and blood pressure. So it's actually at the 4th rep, regardless of intensity, the hemodynamic response is exactly the same. So we see that regardless of whether I'm doing 90% or 60%, at that 4th repetition, the heart rate and blood pressure response is almost identical. But when the person who is doing the lighter weight is able to do more repetitions, that's when the blood pressure and the heart rate start to build. So from a cardiac safety point of view, for those who may be worried about, heart rate, blood pressure excursions going, way out of bounds, theoretically from the handful of data, and I should stress that there's not a lot done in this space, but it seems that the number of repetitions is what's actually driving that, not necessarily intensity. So theoretically, if repetitions is what we're going to halt, we may as well do a higher intensity because we know we're going to get better at adaptations if that's not going to affect it. And so that's just a little bit of food for thought there. Like I said, there's plenty more to do in this space, but certainly some promising starts. The big problem is that for most of us, maybe not those in this meeting, but for most of us, we don't do it. So we know from international studies that only around 10 to 20% of adults actually participate in resistance training on 2 or more days a week, which is the international physical activity recommendations. Um, and we actually know that for those who need it most, those who may be over 50, less than 10% of those engage in resistance training at all. I don't think this was even classified at 2 days a week. So we know all these benefits, particularly for our older populations, but one of the biggest issues is just not engaging with it at all. That's it's a big problem for another day. Well, I said at least we've engaged on this call with some people who have obviously bought into the benefits, which is great. So, what I'm going to do to finish off, because I'm probably a little behind time, so I'll sort of breeze through the back end of this at least. Um, is I'm just going to sort of leave you with a few resources, and then I'll leave you with some practical applications for those who maybe want to try and learn or try something out of this that you may not have been aware of before, or clinicians who might want to try and improve something in practice. So the first one I'm going to give you is something I co-authored with Christian. So this was a new position statement. This one's probably targeted to clinicians, I guess, more than any patients on the call. But this basically, we looked at the recommended exercise prescription, which will cover resistance, aerobic, and physical activity. Um, and we tried to be very practical in our approach to this paper. So I'm going to move on. Hopefully, everyone's had a chance to scan that. And if not, let me know. I can throw the link in the chat. One of the best things that came out of this is a really nice summary figure here. So we sort of, particularly for clinicians in clinic, we had a really nice little workflow here of what your journey should look like as you move through exercise delivery in your service. So all the way from assessing someone to give us a baseline value, which will then let us prescribe an accurate value off that, and then stuff that need to happen in time. So adjustments, reassessing, and progressing to make sure that our patients remain at the level that you're trying to prescribe them at. So if we just were to set a prescription at baseline and leave that for 12 weeks, there's a good chance that by 2 or 3 weeks, you're going to adapt really well to that exercise. And so if you just left that, eventually the exercise wouldn't be quite as beneficial. So really important, that next step, to do the adjustment, do the progression to make sure that we sort of hit that. And one of our key recommendations for this is the importance of individually tailoring. And I guess that goes back to individually assessing and manipulating exercise on a case-by-case basis. So making sure that we can sort of target someone based on their capacity and not necessarily give a cookie cutter to a whole range of people. Just again, to make sure everyone gets the biggest benefits, biggest bang for their buck out of it. Another resource I want to hand on. So this is something that was produced from my group here at University of Sydney. So I would like to give thanks to my PhD supervisor, who is Professor Maria Fiona Singh. She is an internationally renowned expert in resistance training and older adults. She is a geriatrician by training. There's a QR code there that will take you to the ACI website if you are interested. There are a range of different exercises and resources on there, both targeted for patients and clinicians. But for those, often one of the biggest barriers I hear when I speak to people is that we don't have the money or the facilities to get resistance training equipment. So we can't do good quality assessment and prescription. So this is a really nice little, I guess what we would call a 1RM test, the ability to baseline someone and sort of work out what their capacity to be able to prescribe off that. This particular test is going to be really useful, probably for those older demographics, maybe those people who do present with sarcopenia who are a little bit weaker. You'll probably capture maybe 60 or 70% of, if we've got cardiac rehab clinicians in the room, probably 60 or 70% of the patients you see will fail at some point in this test, which is what we want. So typically the way that we would run this test, and what I might do is I do like to be a little interactive with this. So excuse me if I'm a little over time, and Christian, do let me know if I'm dragging on too much. I haven't got too many slides left. But the best thing to do with this is basically treat this as a test to find a baseline value, and then we can prescribe off that. So you'll see the different levels that we have here. So as a clinician myself, the way that I would instruct these type of exercises is that I would normally give the patients a handful of cues, and then basically they try and complete each level until they can't complete one. And whatever their last successful level is, would be classified as their peak capacity, if you will. And then theoretically, if we go and do this test, 12 weeks time after our intervention, hopefully they should have gone up a level. So that's just a nice little easy way of doing something like that. And I guess why don't we do a couple of levels just to get you up and moving, I guess. So if I'm going to pretend that you're my patient, you guys feel free to play along at home. I'm going to give you a couple of key points. We're going to start on level 4, I think. Normally, what I would instruct people is a few really important points. So the most important point is I want you, so if for our level 4, we don't want to use hands, we want to sit up nice and tall with good posture. We want to encourage our patients to keep their knees over their toes or outwards. What we don't want is the knees knocking together, called knee valgus for any of those clinicians in the room. We don't want that as we move. We want to keep the knees basically directly above the toes. And then I also want to encourage breathing. So really important to conserve blood pressure changes. We take a big deep breath in, and then we exhale as we stand up on this exercise. Okay, so if you're my patient, I'm going to say exactly that. Okay, sit up tall, hands on chest, big breath in, and breathe out and exhale. Okay, and so you stand up. If you're able to do that on level 4 or 5, and level 5 basically is do it as fast as you can, and that just places a larger demand. So for those patients who may not have the strength to do it very fast, they probably won't be able to. They get halfway up and fall back down. So that's level 5. Level 6, we add a jump at the end. And again, that's just an external cue to make them move even faster because they have to actually lift off the ground now. And then what we do in level 7 and 8 is we move to one leg. So level 7, one leg, you can choose your leg, whichever one forward. The back leg will have toe support, so it's not fully just on the one leg. And then the same instruction, the very last one is just one leg. And often most people will probably end up at level 7 if they're good enough. Very rarely, younger, stronger people often will be able to do the one leg. It's pretty tricky. Excuse me. So that's a nice little one. I see question in the chat, what's this called? QR code's got the link for it there. It's a sit to stand test, basically. This is not validated. So this is just something that we use in geriatric clinics that we work in. I have had someone tell me that we need to do something with this. So watch this space. We might validate this in the future. But for you guys, I guess it's a resource. If it's something that's beneficial to you or your patients, fantastic, great, do that. If it's not someone, if you're not someone who has access to some decent equipment. So I'm going to rush to the end. I've dragged on a little bit more. So what I'm going to do is the other trickiest part about resistance training is picking your exercises. So I'm not going to hang too long on this slide. I believe you'll be able to watch this video again. So if you want to have another look at it, you're welcome. So my background is in high performance sport. So when we design programs, we sort of don't want to have to think about it because we've got 30 or 50 elite athletes, and we need to program something really well that will keep them really balanced. So we often will program by movement streams. And what you can see in these is that we've got different types of movements on different types of muscles, but not necessarily on a single muscle, on a movement instead. And I find this really easy to prescribe off because if you look on those columns, you can pick anywhere from 2 to you can pick all 8 if you wanted to. And then you've got a really well-designed resistance training program there. And some of the examples I've given you in the pictures there give you some example of, hey, you can do this in body weight, but you can also do this if you've got access to dumbbells or weights machines and stuff like that. So I'm not going to hang too long on this because I do want to finish on time, but that might be a different way to think about it if you've never been exposed to that. And by all means, if you have more questions, do reach out. Happy to explore that more if useful. Quickly going to move through things, considerations for how to manipulate. And I've said how to manipulate exertion in resistance training. There's many other resistance training principles that you can use, but I've sort of picked on the 5 key ones. And if we use even something as simple as the sit to stand that I just showed you in that test, we can manipulate exertion through just changing one little tiny thing. And it doesn't have to be number two, which is our external load. If we don't have access to weights or anything like that, there's a whole range of other things we can actually do, which we can do with body weight. So obviously increasing volume is definitely one of them. External load, yes, but things like tempo. So if you're doing a sit to stand, if you stand at the top, if you go really, really slowly on the way down, so instead of just going down in 2 or 3 seconds, if you try and go down in 5 or 6 seconds at a really nice tempo, that's going to burn the muscle out a little bit quicker. And that's a way of making it a bit harder. Same thing with an isometric hold. So that's basically holding a position still. So you might be halfway into your sit, not quite on the chair yet, and just hold that for 5 seconds. You'll start to feel burning a little bit easier. So there are a couple of tools again that might be useful if you hadn't thought of them or hadn't been exposed to them before. Um, a couple of key considerations, I guess, to leave you with, and then I'll wrap up. Most important thing is do not forget to breathe, particularly for our cardiovascular patients. So um, holding breath or doing like our red-faced bloke is doing over there, it's called a Valsalva maneuver for anyone who hasn't been exposed to that. And it's associated with not great things to do with blood pressure excursions and potentially can put you at risk of rupturing any interventions that you might have had in arteries or anything like that. So really important that we exhaling on every repetition. Um, Technique is most important, and the reason that's most important is to avoid our musculoskeletal issues. And that sort of comes into good posture. Be patient, progress regularly, but don't progress too fast. So you'll all be exposed to those people that want to just skyrocket, and it's always important because that's when injuries happen. So they're better off to take their time and progress regularly than progress too fast, become injured, and then go 10 steps backwards. So that's probably another like I said, very similar to what I presented before. Something is better than nothing, but good habits are needed for success. So, an 8 or 12 week program will do something, that will help someone, but if they never do it again, it's not going to help them in the long term. So habit with this is really important to actually build on, 1 or 2 days a week and try and keep that consistent. And then if you're unsure about any of this or need some expert advice, go and find accredited exercise physiologists. They are the clinicians that are most well trained in delivering exercise to people with chronic disease. I've got a QR code there, which is a link to the Find an EP tool online. If that is something you're interested in or passing on to patients. Um, and that's sort of about it. So I can sort of basically just wrap up. I'm probably not going to hang along too long on this, but sort of just a quick summary of what it is. We know it's important. We know it's often overlooked, but we know it's really effective, particularly in the treatment for sarcopenia. It's definitely safe for the majority of people. Um, um, so get lifting. So that's sort of it in a nutshell. I might just finish with a quick spruik for so Solve CHD, which is the large grant that I work on. So we are basically a national network of people interested in advancing this space. So if you haven't heard of us, we're sort of there's a good network of researchers and clinicians working on this, but we are always looking for patient and clinician input. So there's a QR code there that will let you sign up onto a mailing list. Often when we have research studies, we do want patients to be involved from the outset so that we can make sure that the way we're designing the studies is something that would actually be useful in the real world. So if you're interested in getting involved in anything like that, by all means, jump on board. We'd love to have you on board, and we'd love to engage you if there's any way that we can. So that's sort of it for me. I happy to take any questions, but I guess Do you want me to hand back to you, Christian? But I'll keep my stuff
Yes.
on the slide for now.
Yes, please hand it over, and we'll go from there. All right. So look, thank you for the presentation. Very insightful. Again, like usual, you tend to go over and get away with it, so that's not a problem at all, considering someone who's not feeling the best. But anyways, very insightful. Um, I guess I'll get started with the questions, and I think you might have a few here. So if anyone wants to comment via the chat section, we can go that way. But one question always gets asked, I think it's a practical thing in let's go cardiac rehabilitation setting or exercise programming, when to do the resistance training. I think is always a question. So do you go and go for your fast-paced walk or your aerobic exercise and you're cycling first, and then do the resistance stuff later, or do you start with that first and move to aerobic? I guess that's one question I always get asked quite regularly.
Yeah, well, I mean, all the data out there says that the best exercise prescription is everything. So everything says that, the best prescription you can do is a combination of everything. So I guess that sort of in the context of a broad statement would be the best. So, if you are starting an aerobic training program, whether it is outside or whether it's, in the context of cardiac rehab, the best prescription will be a little bit of everything, because there will be
Mm-hmm.
benefits to everything. There's certainly going to be times when a little bit more care should be taken. So, particularly after someone who has a bypass surgery, who's had a sternotomy, and that sort of, for those who may not be aware, that's where the sternum's cut to do, an invasive surgery, whether it's a valve or whether it's bypass surgery. Um, there is data to show that that is safe within the first couple of weeks, not necessarily loaded heavily, but at least movement. There's some really good stuff that's come out recently to talk about. It's called keeping you moving the tube, and it's talking about the way you should move after a bypass surgery. So what you don't want to do is do nothing. Some surgeons are still saying, sit on the couch, don't touch a milk bottle, don't lift anything, and that actually has worse outcomes. So particularly muscle mass is going to deteriorate if you're not doing anything, and then you'll actually sort of tighten up that scar tissue too. So movement is good. The guidelines, because I've just seen a question, I might build on that in the chat, which is how soon after a heart attack can you start and how heavy? Um, there is enough data out there to say that you can start, as soon as you would start any other form of exercise. Obviously, typically walking is what you would do first, go and get into stuff, recover from what's probably been a crazy experience. But once you're ready to start some structured exercise, there's no limitations on starting resistance training at the same time as something like aerobic. When you say how heavy, what I'd say is how long's a piece of string, right? So um, it's not necessarily, I can't give you the right answer to that because everyone's going to be different. So it's going to depend on training experience. If someone's well versed in doing resistance training, they're probably technically going to be ready for it a lot sooner. If someone's not, I'd still say start, but maybe start at a lower weight and just progress very carefully based on how you're feeling. More than anything. So that's why we do things, like we suggested in that statement we published is consistently monitor, don't go too hard too soon, reflect on the couple of days. We know that there will be a little bit of soreness after weights training in the couple of days after it, and that's completely normal. But sort of just not going too hard and reflecting on that and progressing slowly,
Think
and I guess to sort of finish that one off, Joe, is there's been plenty of clinical trials where they've got up to something like 80% within 2 weeks. So there is some evidence that's in a very controlled setting. That's certainly not in the real world, but there's certainly evidence that it can be done. But it's probably my recommendation is it's on a case by case basis.
I'll I'll just jump in on that, and obviously, my views as well with this type of training. But typically, look, it depends on heart attack. Stent patients, I mean, technically can resume back quite quickly within 3 to 7 days, actually, after a stent, and especially when we're talking about aerobic exercise activities. Typically, with resistance training, because of, I guess, depending on the techniques, if people aren't breathing, those type of things, can increase kind of like blood pressure and things when you're doing these type of things. But the general rule of thumb is anywhere between 2 to 4 weeks. And when we start to look at stenting, you start to go towards more than 2 weeks. When you look at cardioversion, in actual fact, you can go the next day. What we're finding is that exercise is far more safer, far more, able to be done by patients with heart disease. And in actual fact, we actually shouldn't be so conservative and wait so much. We should actually start to do it much earlier. And like Matt knows, there was some stuff done a couple of years ago where they got patients actually in bed following a bypass, if I recall correctly, and they
Yeah.
tracked
Yep.
them. They started them actually from an inpatient setting a day or two after from the bypass surgery. And at 6 months, they were far superior compared to those who actually started at the 4 week mark and what they typically do. So it is starting to shift towards that direction. But I think probably the biggest thing I could say is that they're safe to exercise. Definitely at the 4 week mark. They should be ready to rock and roll by then, huh? What do you reckon, Matt?
Yeah, definitely. And like you say, challenge you even sooner if feasible.
Yeah, I mean, at least, yeah, and that's and by those comments, we talk about height, we talk back to normal, high intensity, maximal effort. So typically, if it's say like a bypass patient, we would say maybe 4 weeks for that. At 2 weeks, you can definitely be resuming low to moderate type of activities, if that makes sense. So when we always talk about what when you can go back to pretty much doing everything, if you can do it, I guess that's kind of what we talk about really. And that 4 week is kind of that magic number sometimes in a lot of things. So yeah, I guess any other questions anyone may have around resistance training? I guess Matt, like I said, it's a good way to link in with aerobic and resistance training, even if it's albeit a little bit. I think that's quite important. I don't think people should shy away from little, basic type of using your body weight for resistance training, whether it's a sit to stand, whether it's a squat, whether it's a lunge. I still do body weight type exercises, and I'm still sore. So it doesn't matter whether you're young or old. These exercises are quite effective. We've got a question. Do you have any links for moving within the tube as we're looking to structure our resistance training and rehab in the safest way at the moment? It's super key cutter.
Yeah, so I'm Googling on the other side here. There's certainly a few links. So I mean, even something as simple as Googling "keep your move in the tube." There's a few videos that so this came from Canada. What I can do is I can throw. I don't know if everyone can access journal articles, but what I will do is I'll throw the journal article that was the first one to publish this in the chat. And then I'm probably happy to just let you Google the rest because there's some pretty decent videos out there. The theory behind this is that basically keeping your movement as if you're moving inside a tube. So what you don't want to do is move outside of here because what happens is we get too much external movement, and that's where issues can happen. But if like as if you were inside a tube. So anything sort of nice and close to the body in vertical like this, there's a lot less movement at the sternum. And so it's going to be a lot safer in that early phase of recovery from a sternotomy. So hopefully that's a good start. Like I said, I think Google is probably your best friend there because there's some good videos there. And, the first one that came up on Google was a really nice little video with where they look like they've got a clinician, they've got some really nice stuff embedded in the video. So that's probably the best place to go because there's enough documented on it at the moment. There's some good reading you can do there. Hopefully
Right.
that
All
answered the
right.
question there. Yeah.
I don't
Cool.
think any other questions.
Can I
Um,
can I jump in and ask one
Yeah,
question?
Bob,
Bob.
go for it.
Okay. Look, in Matthew, thank you very much. It was a really, really good talk. I'm glad I tuned in. But in one of your slides, you had the benefits of the resistance training, and you had a section there where it said depression, anxiety, and stress, and each one of those had a question mark. Is there a reason why there's a question mark? Because from my personal experience, it's definitely improved from the depression point of view. I'm just wondering, hasn't anybody looked at this to decide whether it does help or not?
So that thanks for the question, Bob, and I'm glad you enjoyed the talk. So that particular figure was taken from a cardiac rehab paper. So what they're saying is that and I probably haven't read well enough through there to comment on it. I know certainly across the broader scale that there's quite good evidence that it improves a whole range of mental health, and particularly cognitive function as well, which is really closely associated with that. So most of my, a lot of the trials that I've been involved with as I was sort of coming through my PhD was with geriatricians who are working in that space. So I know, there's definitely known. We've got a few depression studies at the moment happening with the resistance training. So I certainly know you are onto something there, but I think that particular figure was just in cardiac rehab, and I think just not enough has been done. So that's the only reason for the question mark there. It certainly applies to the broader populations or different diseases. But yeah, there's probably just more needs to be done, I guess, in that group. But thank you for the question, Bob.
All right. Well, on that note, we'll leave it at that. This presentation, like usual, will be put up on our website. We'll circulate it to our peer support group leaders across the country and make it available to anyone who'd like to access it. So again, Matthew, on behalf of Heart Support Australia, thank you very much for the insightful presentation. I knew it was going to be a very good one and a very interesting one, even though I'm an aerobic exercise expert. I still think that's actually more important than resistance training. I'm joking. Of course, the two are very important together. But thank you very much. I appreciate it, and wishing everybody a good night. And if there's any questions, feel free to direct them to us in the office, and we can help put that through to Matthew if there's anything, or we can answer it ourselves. So thank you again, and have a good evening.
Excellent. Thanks for your time, everyone.